Can't slide that. Sal said she was going to do it. Share slide.
Hi folks, and thanks for joining us again for this webinar. My name is Charlie Wilbridge and I work on the Mind Out project here at the LGBTI Health Alliance. You may also have received emails or phone calls from me as I'm the main contact for the PHNs. Before I start, I'd like to acknowledge the traditional owners of the lands on which we meet and work and pay my respects to their elders, past and present. Today we have our fourth webinar for Series 1, and we will be introducing some things that are important for you to consider when thinking about programming or designing programs or frameworks for LGBTI people who may experience interpersonal or family violence. Today we have two presenters for you, Ross Jacobs, who is the National Clinical Director of QLife here at the Alliance, and also Moo Bolsh, who is CEO of Domestic Violence New South Wales.
Hello everyone and welcome to our webinar series for the PHNs. Today we're talking about intimate partner and family violence. So this is a topic that some of you will specialise in. This is a topic that some of you may come across in the course of your ordinary work at your PHN level, depending on what sort of programs you're already offering. But today we're trying to talk to you and opening up the space of what this series of personal conflicts and sort of really difficult times in people's lives looks like for LGBTI people in specific. So let me just get through to the next slide. As you're already probably aware, if you've joined the series before now, the National LGBTI Health Alliance is the peak alliance that's membership based. So all of the people that participate in the conversations we have here at the Health Alliance are working with LGBTI people. And what we aim to do is to gather those voices and to provide policy and professional sort of advice to government and other key players in the health space. My name is Ross Jacobs. I'm here with Moo Bolsh, and we'll get started into the content. So I just wanted to spend a little amount of time. Again, this is familiar content to you if you've been on board the other webinars, but just really explaining what we mean by LGBTI. And so some of you may be familiar with this acronym. Some of you may be familiar with different acronyms like LGBTIQA. And the way we use LGBTI here at the Alliance is shorthand for lots of other ways to use it as well. So we're trying to be as embracive of people's identities and histories as we possibly can. And of course, by LGBTI, we mean lesbian, gay, bisexual, transgender, and intersex, from which there are three distinct categories of personal backgrounds that people bring to their LGBTI identity or history. So we're talking about people's sexuality, we're talking about people's gender, and we're talking about people's bodies, all of which can overlap in terms of the way people have lived experience, but they can also be very discrete and individualized and the only issue people think about. So some people think about their sexuality when it comes to identifying as LGBTI. Other people think about both their sexuality and their gender, and lots of different combinations around that. So before we get into intimate partner and family violence, I just wanted to spend a small amount of time talking about some of the underlying societal-wide issues that a lot of LGBTI people live with on a day-to-day sort of lived experience level. And the key one of those that you may again have heard before is internalized homophobia or internalized transphobia. This isn't yet coined to be embracive of intersex people, but what we're talking about here is an idea that people learn through their childhood or their adult life that being LGBTI is somehow inferior to being heterosexual or cisgendered or both. It's this idea that we self-police in some ways after having taken on board some negative messages from society about what it means to be LGBTI. Often this looks like people deliberately, with some awareness, toning it down or denying who they are, so not being openly LGBTI. It can also express itself, and what I think is relevant for a lot of people is this idea of hypervigilance. So every moment of every day, particularly in public, LGBTI people are very aware of their status as LGBTI, and it's not something that's ever far from their mind, just in case issues of conflict or surprising moments of discrimination can come along. So what this ends up looking like is this concept of minority stress. This is not a phrase I'm necessarily comfortable with, but it's the current sort of name of what the phenomenon is. What I want to be very clear about, though, is that minority stress is not the fault of the minority. This has got nothing to do with being part of the minority inherently, and this is a theme we'll probably come back to more than once in today's presentation, but it's about the experience of existing as a minority in a wider society that doesn't necessarily embrace who you are. So it can involve experiences of stigma, experience of prejudice and of discrimination. And this can happen on the bus, this can happen when you're ordering a coffee, this can happen in your workplace. These are moments where the hypervigilance that people go through, the day-to-day stress, the bodily stress that people experience, is meant to prevent flaring into conditions in which people can end up really unwell, because we all know what stress does to people. So I hope that's a clear sort of concept around what it is to be living daily with minority stress. So linking through to intimate partner violence, and we'll talk a little bit more about family violence in a separate section, but what we want to sort of lead this discussion with is that intimate partner violence is possibly present in any kind of formatted relationship. We know it's true in heterosexual and cisgendered relationships, and what we're talking about today is when it's true for LGBTI people and in their relationships. It's also worth importantly highlighting at the start of this presentation that there is a lack of the huge research base for LGBTI people when it comes to this stuff. It doesn't mean the research we have isn't really strong and robust, but it's not as hugely numerous as the studies around intimate partner violence for Australian-wide contexts are. So this leads to a potential lack of recognition that intimate partner violence is true for LGBTI people, and that lack of awareness can also be true for LGBTI people, not just mainstream service providers or mainstream Australian society. So in a funny way, what again that leads to is a lack of talking about intimate partner violence within LGBTI communities, and certainly no very public sort of role models, as it were, like your Rosie Baddies and people like that within LGBTI populations. So the specific impacts we're talking about on LGBTI people can be that within their intimate relationship where violence is occurring, people get really cut off from their family supports. It's this idea that the relationship itself becomes something that's quite controlling on people, a familiar concept within intimate partner violence spaces. But here, what exacerbates that a little bit is that LGBTI communities are often quite close-knit. So to withdraw from supports that are quite small networks means that people are often left with very little support at all. One of the myths that we sort of want to bust today is that there is some prevalent belief that intimate partner violence for LGBTI people is often just a quarrel between equals, or that there is no power dynamic at play. And as you'll see from some of the content we'll be presenting, that's certainly not true. And just because people are of the same gender, if that's the circumstance we're talking about, doesn't mean that there are no sort of control and power issues going on. But what the research does tell us, just like in many other instances of intimate partner violence, is that without professional intervention or an ability for people to seek help, the violence often escalates within relationships rather than just ending of its own accord. So based on a few studies that do exist and that are out and about, this is just 3 examples. There are a few others around that we'd be very happy to email through if people are interested. What we can see here is that the numbers in terms of the statistical prevalence of intimate partner violence for LGBTI people both mirror and are quite different from the society-wide numbers that we're aware of from your big studies like from your NROs, MOBS, or Our Watch, or people like that. So what we can see here is the 41% on the screen is pretty representative of the overall statistics we see from those larger studies. Broken down within here, and I haven't included it today, but there is some variance between male same-gender couples and female same-gender couples. Tends to be a little more prevalent, at least in the studies we've seen, among female same-gender couples, but international research says that they're pretty similar. So we just don't really have the strongest research base here in Australia to be able to definitively say that, which is why I've included the one higher statistic for both genders of same gender couples. Moving on from that, a relationship in which one or both participants are trans or intersex, the numbers go up a little bit to 53%. And that's what is as self-reported physical violence. So the idea that the conflict that's going on within the relationship and the power and control issues spill over into physical confrontations and physical force. But the highest statistic as represented on this chart is for when trans and intersex people in relationships experience emotional violence directed at them, and we'll break that down into what that can look like for LGBTI people a bit further. So what we mean when we talk about intimate partner violence for LGBTI people is both what you're probably already familiar with, and we've touched on a little bit, that is represented in other populations or more mainstream populations. But there are unique forms of violence that occur for LGBTI people that you may not have thought about. So it's really important when you're thinking about what kind of work you're going to be commissioning or what kind of gaps that are existing in your service, that these are the kinds of relationship violence themes that also need to be considered and addressed when it comes to working with individuals from our populations that are in violent situations. So there are all sorts of complexities related to these, and people's own lived experience might mean that they're more at risk of some of these than other people are. So for instance, within the first topic, we have threatening to out people. So this idea that when there's a conflict going on, people are essentially having their identity as an LGBTI person or their history as a trans or intersex person held against them as something to keep them in relationship, or as something to effectively be like, but I'll tell your workmates that you're trans, or I'll tell your parents that you're gay. And that's a real form of emotional control. Above and beyond that, that can spill over into using homophobia and transphobia and systemic barriers for LGBTI people against the other person in relationship. So the example we've got on the screen here is this idea that partners can hold control over custody of children against other partners, and really digging down into that layer of internalized homophobia that I was talking about earlier. right too that some people, even though they're very possibly LGBTI themselves, but also too remembering that some transgender people have heterosexual partners, some LGBTI people have partners that identify as heterosexual. People can use that internalized homophobia against the other person in relationship. So this idea that they deserve what's going on in relationship because they're not as good as other people, and that they can't expect the kind of quality relationship that other people can expect. And there's also a highly specialised specialised, probably not the wrong word there, but a highly sort of unique form of partner violence that goes on between people when one or both partners is HIV positive, and all the stigma that comes along with the disclosure of people's HIV positive status. So a lot of what we've talked about so far has been intimate partner violence, but it's really important too to consider what family violence looks like for LGBTI people. And often, again, this is a very personalised lived experience of individuals, because some people have huge family support and don't experience any kind of conflict within their families. But it's certainly true that people from within LGBTI communities do experience this stuff. So sometimes the act of identifying as LGBTI or having an intersex body or whatever it happens to be for the individual really separates them from their biological family. And for young people in particular, this removes a layer of support that it's very difficult for them to function without. So we do often hear stories of young people needing to flee the family home and ending up in situations of homelessness or couch surfing, in which their family of origin is not supportive of their identity. For intersex people, and this may be information that's new to the PHN audience we're talking to today, the violence of the family against them can occur from a very early age in terms of medically unnecessary surgeries in which genders have been assigned by both medical staff and often through the pressure of medical staff by the family involved too. And when individuals hit an age of puberty in which their body starts to develop in ways that are potentially not in alignment with the gender that has been chosen for them, and they start to experience their bodies and their gender as something different to that assignment, there's some violence that intersex organisations tell us is very prevalent in such a circumstance. That's also true for trans people when they start to articulate that their true and lived experience of gender is not something that the family relationship model is built around. And so there's a high level of resistance that can occur from families against all levels of LGBTI. So against identification around sexuality, against trying to affirm one's gender, and against being honest about one's intersex status. So when it comes to the landscape I've just laid out, I think what's important for the PHN group to think about is what is best practice in this space, and how can we do interventions with intimate partner and family violence with LGBTI people in a way that is as inclusive as possible. We would suggest that educating yourselves about LGBTI populations is the very first step that you must do, and acknowledging that every PHN across Australia has vibrant and numerous LGBTI communities and people within it, and that often the systems that are set up at a hospital and a public health level are just not inclusive of people's identity as LGBTI. So I know that there's a data collection forum that's either already happened or is coming up, but this idea that if you're not careful, you will be erasing LGBTI people at the very point of intake. And without a statistical data set that I was talking about before, no changes will occur at all for LGBTI people. So it's really important to be as embracive of people's identities and histories as you possibly can be. And in alignment with that, LGBTI people who are currently experiencing intimate partner violence or family violence will probably not disclose to you the fact that this is going on for them if they don't trust that your service understands LGBTI people, or that the individual worker they're working with doesn't understand LGBTI people. So all of the messaging we've been telling you across this webinar series, from who are LGBTI people onwards, needs to really be bedded down into acknowledgement, not only that we exist, but being very culturally appropriate and sensitive to how you can work with LGBTI people. So once this is established, it's then about understanding that violence within LGBTI relationships is often related to non-acceptance of one's own LGBTI status. But that this is playing a role in what an individual is going to need from services to disclose what's going on. So it's a little bit tricky there. You can't just be really sort of best practice in terms of your openness and friendliness to LGBTI people. You need to also understand what it is to struggle with an LGBTI identity, and to not judge someone who might be in a space of not knowing how to disclose, or someone who doesn't yet have the words or is comfortable to describe themselves in LGBTI language, because there's all sorts of ways people lead their lives depending on what their own personal journey with LGBTI has been. So making sure your service is not adding to discrimination or adding to any kind of messaging around internal judgment is really important. So some very simple barriers to help seeking that I know have been presented in other webinars, but I just wanted to add a special sort of intimate partner and family violence theme to, is that it's important not to assume the heterosexuality or the cisgender status of people when you're going through your standard process of intake, and putting the burden on people to tell you rather than you being able to provide spaces in which either party can ask that question is really important. So the arena in which this is often at its heightened peak is within a refuge system, where people are highly vulnerable, have left so many of their support structures, and then put into a space in which their own needs around identity not met is a really terrible outcome for LGBTI people. And having staff that are adequately able to give support to people who are seeking refuge within this space is really important. So from that short list there, it's just important for you to be considering your services and your space, and to think about what you might be able to commission to make some of this stuff really change. So from the barriers we just expressed, this is the reality of what we know people in violent relationships who are LGBTI are not doing. So we know that men are far less likely to report that the relationship they are in is violent, and that they need assistance around that. But that doesn't at all diminish that women are also not reporting at over 50% to health services when they're in a violent relationship. So that's just a little sort of staggering statistic around how important getting your processes right is, because to have close to 70% of people not reporting when some professional assistance can make all the difference is a really important message, I think. So this little diagram here, I think, just has been included to highlight that taking care of one of these elements is not quite enough when it comes to working with LGBTI people and intimate partner violence or family violence, because all three of them are significant barriers to people seeking help, and should be the ways in which your PHNs are thinking about how to introduce specialised services to help LGBTI people, or to tailor existing services to the needs of LGBTI people. we'll go a little bit into some specialised recommendations that a really great Victorian Royal Commission into Family Violence has recommended, so that the findings were put out this year, and Moo will walk you through some of what that commission has said to us as really possible and best practice outcomes for working with LGBTI people and intimate partner violence. So I'm going to hand over to Moo now to take us away from a theoretical space and a bit more into the work of DV New South Wales.
Thank you. Okay, so we're going to talk a little bit about understanding what the impacts of domestic and family violence, intimate partner violence and trauma might be, specifically for LGBTI people. You can see on this slide that we talk about trauma being trauma, and the impacts of trauma. I think we're starting to understand a lot more, particularly in the last few years, and particularly in relation to violence that might be experienced in the family or intimate partner context. But we certainly have a lot more to know, and people's journeys are very personal in this space, as we know. So Ross has talked a bit about some of the context, particularly in terms of service settings, the sorts of environments in which we form our relationships, and some of the barriers that LGBTI people may experience in terms of, firstly, identifying that they're in an abusive relationship, secondly, seeking support, and then when they get to that support place, or they get to the place where they feel comfortable to have a conversation with somebody and reveal for the first time that they think they may be in an abusive relationship, how important it is that first response is really sensitive and really, you're using the right language. People are aware of what the context might be and what some of the implications of might be in terms of some of those fears and barriers. So we know that everybody responds and recovers differently, but trauma, certainly complex trauma and intergenerational trauma, which we see both within our LGBTI communities, but also specifically in other communities, culturally and linguistically diverse communities, for example, newly arrived migrant communities, Aboriginal communities. We often have really complex intergenerational trauma, which can also add extra layers of difficulty around seeking support and identifying that abuse in a relationship. And that can impact on people's ability to form new friendships and relationships after the violence. Certainly some of the work that we've done working with gay men and lesbians, for example, after they've left an abusive relationship, they identify that it can take a really long time to get to the point where they can trust anybody again, whether that's just in the context of making new friendships. Most people, when they've been in an abusive relationship, have some challenges around trust. But I think when you have those extra layers of maybe sexuality, gender, intersex, perhaps race or culture as well, maybe disability, there can be all sorts of blocks to actually being able to get to the next stage, to be able to trust and form new and healthy relationships. We've talked a bit about the fear of authorities. Certainly some of the research that we've done in New South Wales in the last 5 years or so, really talking to people who have been in abusive same-sex relationships, shows that even when people do find an agency or a service or a person who understands understands some of the intricacies of intimate partner violence in the LGBTI context, there is a real fear of homophobia. There's a fear of reporting to police that you're not going to get the support that you need. And what's so essential in this area, I think, is as with other small close-knit communities, it only takes one bad response and that news goes out across the community. So one bad police response, one bad response in a health setting, one bad response in a domestic violence specialist service can really have ripple effects for right across the community. Excuse me. The ability to form new relationships we've talked about a little bit. I think certainly we've seen some work in terms of LGBTI organisations teaming up, working with some of the domestic and family violence and family services over the last few years to really find ways of working together and sharing expertise across those two spaces. Obviously, trauma is one impact, that fear of not knowing whether the next relationship that you get into is going to be abusive as well. But I think there's another added layer that we see a lot. We know that young LGBTI people are incredibly vulnerable in their relationships. Ross has talked a bit about the fact that we don't have, lots of healthy relationship models within our communities, and so certainly one of the key things that we see as a fairly unique type of abuse that occurs often in LGBTI relationships is that sense that a perpetrator of violence can use that as a form of control in the relationship. So they might say, "This is what it's like in gay relationships. It's normal. It's normal to be, to be watching pornography. It's normal to be going to sex parties. It's normal to be, there's a whole range of things that we set up around those relationships, and people can be incredibly vulnerable because they just don't have access to those models of healthy relationships. So it really comes down to choice. There's not really that much of a difference. The power and control and the trauma are very, very similar, but some of the tools that people use to abuse within relationships just might look a little bit different in the LGBTI context. And Ross has talked a little bit about some of the other social determinants of health already. So we know certainly within our communities there are high levels of drug use. We know that schools are one of the most violent places for young LGBTI people. The family is the second most violent place, as we've already talked about. When you're growing up and you're growing up with society, your family, and the kids in school telling you that you're not okay and you're facing that daily abuse on a daily basis, it can be incredibly difficult to form a strong, clear, healthy sense of self. And that impacts on forming healthy friendships and relationships later on. So all of those underlying factors certainly impact pretty strongly on LGBTI people's ability to identify abuse in the relationship context, to seek help, and to form healthy relationships. So we're going to do a couple of case scenarios. These are actually based on cases of people that I've worked with over the years. I don't know how it's going to work in terms of being able to get some interaction from you at the end of your computer or phone, wherever you are. But I just wanted to share a couple of examples of really simple things that we have come across over the years, and just maybe even if you don't get an opportunity to interact with us around this, maybe you can think about how this might impact on the practice in your space. So James was a 17-year-old. He identified as gay. He was admitted to the emergency department in a regional hospital, and actually James came to seek some support because he found a really good person within the emergency department who was quite practiced at working with intimate partner violence in the heterosexual cisgender context, but had no idea what to do with James. He was being really badly abused by his partner, who was also his carer. And this is, again, something that we see often within LGBTI relationships where one of the partners may have a disability or a chronic illness. Ross mentioned that sometimes we see some abuse, particularly around preventing somebody from accessing medication. It might be medication for HIV or some other chronic illness. But certainly for trans and intersex people, one way of abusing a trans or intersex person is to be forcing them to present in some particular way, forcing them to have surgery perhaps, forcing them to have hormones, or preventing them from accessing any of those things. So really taking their choice away around the ways in which they want to present that day. And it can be as simple as, you know, you should wear more makeup or you should wear different clothes. But in James's case, he was brought into the emergency department by his partner slash carer. There were some signs that he had been using drugs fairly recently. He had some pretty severe physical injuries, but he really wasn't in a state to be having a conversation with staff there in the emergency department at that time. Now, certainly in some hospitals, I know that if this were a heterosexual woman, then staff would probably try and remove the partner, you know, take them away, have a conversation with them separately, and have a conversation one-on-one with James to really ask some of those basic questions. Are you okay? Are you safe? Who's done this to you? Fortunately, in this set of circumstances, the health worker was able to have that conversation. Somebody else took the partner away for a cup of coffee, and after a fairly gentle conversation, James revealed that he was experiencing power and control within his relationship. We have a series of questions in a number of different health scenarios around routine screening for domestic violence, but often these are not used where staff suspect that there may be domestic or intimate partner abuse in a same-sex relationship. Some of this stuff is highly skilled, but some of it is also just about being able to find a sensitive way of having the conversation and asking somebody if they're safe. You know, in this case, James was really happy to have a conversation. He was happy to talk to the staff once he knew that the drug use was not going to be an issue for them. They had been using drugs together. But as I said, it took some fairly sensitive, nuanced conversations to be able to have, to be able to get James to a safe place and be able to talk more about what his options might be. So if anybody has any questions on these as we go, maybe you can type them in and I'll answer stuff as we go. Come on, slides. So this is another example. More recent, a woman in her late 30s came in with two small children to a health service. She was actually she came into a service because police had received a call from the neighbours that there was an altercation going on. There were no signs of physical injury either to her or to the children. And so police had left and were, you know, she had been referred in to a service. When she arrived, she was very upset, very fearful, particularly around the fact that her children had been involved when police had turned up. There were lots of fears around whether there might be implications of that in terms of child protection. And she revealed that there had been a dispute after her ex-partner had dropped the children off, and that her partner has now left the house, and that she was there, and that she felt relatively safe. This was an interesting and difficult set of circumstances in that there weren't family court orders in place, and so part of the fear for this woman was that she had that there may be some implications for family court. after she did find a good health worker who was able to sit down and spend some time and start fleshing out some of the intricacies of this situation. She said that she hadn't been physically injured, but that she'd been receiving a series of escalating, harassing text messages and phone calls from the ex-partner. The ex-partner was threatening to take her to the family court, and she was told, "I'll get full custody of the kids. They're never going to believe you. This is a same-sex relationship. I have high standing both within the LGBTI local community, but also her partner was a lawyer as well, so she had access to not just money, but also other people within the community and good standing within that community." And I brought this as an example because I think this is something that we see, again, relatively commonly within small, tightly knit communities. This actually occurred in an urban context, but even within our urban context, our communities can be very, very small. And it can be very difficult to firstly reach out for help and find somebody that is a safe person within your community. And secondly, to find a way of actually moving on once you've made a decision that you do want to leave that violence, being able to access, legal services, support services that understand your needs as a queer family. I think in this case there were also some issues around the sperm donor who was a friend of the ex-partner as well, and so you can sometimes see that the layers of violence that might be occurring in the intimate partnership may ripple out to other friendship networks within that community, or more broadly outside the community as well. And this woman was really very, very fearful about what the implications might be in terms of her access to her children. So the next one we're looking at is something that you will come across without doubt in your PHN at some point. Certainly over the last few years, we, I think, and the Health Alliance and others have done incredible work in terms of training workplaces to be much more sensitive to disclosures of sexuality, gender, intersex at work. So this local PHN worker has come to you as a manager and has said that he thinks he may want to transition. His wife is threatening to leave and take the children. She's not coping at all, although she has known about this for some time. And he thinks that it may be the fact that he has connected up with a couple of local LGBTI support services, and the fact that he's now speaking more openly about his gender and more comfortable with that, that has brought it to this point. She's preventing him from accessing an endocrinologist. She's also said that she wants him to continue presenting in female clothing when he's around the children. She doesn't want him to access other medical support. There are a range of ways in which she's really restricting his ability to present in the gender, in his gender. And he's very, very fearful. He's fearful not just of the reaction of his co-workers and other people within the PHN, but also very fearful of what the implications might be in terms of his children, other children's parents, and again, that ripple effect, more broadly outside of the family context. When the PHN worker talked to him and discussed this in more detail and was supportive, one of the things that he revealed was that there were a range of other ways in which he was being controlled. And he wasn't sure that he wanted to leave the relationship. He wanted, if possible, to be able to try and find an amicable way to continue to have a relationship with his wife, whether that be in an intimate partnership context, but certainly with his children. And so we see in this example the way that a range of different outside factors can impact on somebody's ability, firstly to talk about a range of types of behaviour that might be happening in that relationship, but secondly to reach out and get the support that you need, either within your workplace or within your friendship circles and networks as well. And I'd be really interested to know if, excuse me, if PHNs have policy around this sort of situation. It's a very common one. And certainly, as Ross has mentioned, we know that one of the really powerful tools that partners often use against trans and intersex people is threatening to out their gender or intersex status in a workplace or to family or friends. And this can happen in small isolated communities and will have huge impacts on people, but it also impacts significantly on people in urban contexts as well. Not clicking hard enough.
Right, doesn't like it, does it?
So just wanted to touch a bit on the Victorian Royal Commission, because this really is it has massive implications, not just for the jurisdiction of Victoria, but also certainly for all of the other states and territories. The Victorian Royal Commission was a very extensive process. For those of you who haven't had a chance to have a look at it, it's actually volumes that stretch far wider than I can show you on the screen, but it has some really significant recommendations in terms of next steps forward in a range of different policy and service settings. So it made some very strong recommendations in relation to LGBTI, intimate partner violence and family violence. We've seen very little investment in this space, and part of the reason that we don't have that really robust evidence base looking at what the context is in different states and territories is the fact that this just hasn't been prioritised and seen as an area of need and of worthy of attention over the last 20 years as we've been developing things like the personal safety study by the Australian Bureau of Statistics. But certainly when we talk now about domestic and family violence, there is a real recognition that LGBTI communities and relationships have those range of barriers to reporting and that the prevalence is pretty high in comparison with other communities. So it's a real priority, I think, both within the Royal Commission and within the Council of Australian Government's Third National Action Plan announcements, which occurred last week. So the Victorian Royal Commission talks about prioritising research, which is great because we need to know more. Certainly one of the things that we don't know much about at the moment is when people report being in an abusive relationship, we often don't know if that is in the context of a same-sex relationship or a heterosexual cisgender opposite-sex relationship. So the stats around gay men and lesbians say roughly 1 in 3 gay men and lesbians have experienced violence in their intimate partnership, but we don't have the really solid evidence base around that being in a current same-sex relationship or otherwise. Obviously, one of the areas of real change I think that we will see over the next few years, and this will be not just in Victoria but also in other jurisdictions, is looking at the standards for service provision and data collection. In a number of jurisdictions in Australia, there are practice and best practice standards around working with people who are impacted by domestic and family violence. Some of those jurisdictions include LGBTI as a priority group, others don't. It's an interesting time, I think, because we're having a huge conversation about domestic and family violence for heterosexual cisgender women, and quite rightly. But we need to work out how we can have that conversation and acknowledge using a gendered a gendered analysis of domestic and family violence, because of course the majority of victim survivors of domestic and family violence are heterosexual women and children, but being able to include LGBTI in that. One of the other recommendations was education and training. It's a bit of a no-brainer. Certainly we know that some efforts have been put in a few states and territories in terms of increasing the ability of domestic and family violence services to work better with LGBTI people. Some of that's about the way that you have intake forms and processes. Some of that's about the way that you actually physically set up premises. So if you have, facilities where somebody's going to be staying for a few nights or longer, thinking about how you might need to adapt them or make some safer for trans clients, for example. In New South Wales here, we still have a strange system whereby some women's services can actually apply for an exemption and don't have to allow trans women in, although I'm happy to say this is something that very few services use these days. But certainly it's not good enough just to stick a rainbow flag on your door or in your waiting area. You really need to have good training with staff around understanding how to work with LGBTI people in your service setting, whatever that might be. Another recommendation was around developing specific resources around legal pathways and other support pathways, specialist counselling pathways. And when we think about this, we also need to bear in mind that LGBTI is not a nice kind of common kind of gathering of people, and we can say this is what the needs of LGBTI people are. We're hearing a lot more about intersectionality now, and thinking about those layers of race, family background, homophobia, transphobia, biphobia, discrimination against intersex people, as well as drug and alcohol, mental health, disability. All of those things need to be taken into the context when you're dealing with somebody who is in an abusive relationship, regardless of sexuality or gender. So it goes beyond just the relationship that they are in, or the family context that they are in as well. We've talked a little bit about LGBTI specific and safe accommodation options. Certainly, if you're escaping domestic and family violence in most states and territories in Australia, there are very few services, LGBTI services, that you can access. There's nothing federally funded by the government. There are a couple of small services here in New South Wales, and there are a couple of things in Victoria as well. But there are very few LGBTI domestic and family violence specific services. So some of the research that we've done with LGBTI people around intimate partner violence, we've asked them what kind of services they would like to access. And more or less 50-50, they said they would prefer to access something that a service, so I think PHN is a perfect example here, a place where they can be safe within their own local area. So having maybe a champion within your context, somebody who really takes this on as an issue and is able to educate other staff, is able to work with LGBTI organisations and people to try and improve your practice in this area. It's a really great opportunity to be able to improve things in a whole range of ways. And community education campaigns. We're not good at talking about this stuff in our communities. We have an incredible amount of violence that is coming in from the outside at the moment. There's a very vitriolic conversation around LGBTI people and relationships and families in the mainstream media at the moment, and being able to have a conversation about an abusive relationship in that context where you've probably been isolated from your friends and family. You may not believe that there are any services that want to seek your help. Your community, it may be supporting the perpetrator because they may have, some level of standing in the community. It can be incredibly difficult to step outside of that and have the courage to seek help. So really thinking about how we can have campaigns within LGBTI communities, and I think PHNs have to be a really important part of that. It could be as simple as having a stall at your local LGBTI event during Pride or Mardi Gras. It could be about having content in online or in your local LGBTI media. Just really reaching out and making it clear that you are a safe and friendly place. So. That's not my slide.
No, I think we're at the end.
Does anybody have any questions? Because I'm really aware that we've gone through a lot of material there in a very short time. You're all very quiet.
Looks like everyone's thinking. Well, if there are no questions, Moo, perhaps we'll wind it up. Was there anything else you wanted to add before we finish?
I guess just we've come a long way in this area, and it's interesting with a colleague that actually some of the very first work in this space was done up at St Vincent's Hospital in Darlinghurst. So here in New South Wales, we have a thing called the LGBTIQ Domestic and Family Violence Interagency. It's the longest acronym on earth. Yep. We love those in our community. And way back in the early 2000s, during the AIDS crisis, there were health workers at St Vincent's Hospital that identified that there were gay men who were presenting, and it looked as if they had similar kind of issues to heterosexual women who were in abusive relationships, and nobody had had the conversation up until that point. So here we are on 15 years later. We certainly have some amazing resources that are available. If you hop online and look for Another Closet, that's it's a New South Wales specific resource, but it's an excellent resource for service providers, anybody who's thinking that they might want to take some steps in terms of improving their practice. And it's a great one to give to LGBTI people who think they might be in an abusive relationship as well. So we're getting there slowly, but we've got a long way to go. And I think a big part of that is the conversations we need to have in our communities.
Yeah, I agree. So excellent way to finish, I think, Moo. Thank you very much for your expertise and letting us into the work of DV New South Wales a little bit. Thanks, everyone, for participating. If you do have any further questions that come up as you're thinking about this or rewatching this over the upcoming period of time or showing it to your staff, our contact details are on the screen there. You can reach Moo directly at that bottom email there. Otherwise, we've got some specific pathways for PHN communications to happen within the Health Alliance moving forward, because we're here to work with you guys. So thanks very much for your participation, and we'll see you at the next webinar. Thanks again, Moo.
Thank you.
Copy that just in case we don't get it again.